a channel which they had never explored before. So the patients are brought in, on one hand prevented, and the other hand they are brought into the hospital. And the hospital, then you should use the hospital information system to manage the large amount of people entering into the system and have an enterprise-wide hospital information system to fasten this process and provide better care to them. And later, of course, and you may not be able to reach, but you should have, the patient should be able to have their own patient records to see where they stand and how they go about. I think what I'm saying is that although all this is happening in US or in any other developed countries, in India, the government can promote this by starting with the local population who don't make an attempt to reach or do not know what kind of health problems they have. And so if we reach to them, you will be able to promote and bring the patients to the hospital.
Thank you very much.
Thank you
for coming. Yeah, I now request my panelist, just in 2 lines.
Yes, sir. Surely, sir.
Yeah, just in 2 lines. What should we take away from this panel? Which organization can take note that what can be done tomorrow and day after, not in 2020?
So firstly, responding to the lady there, I think there's already a load on our hospital ecosystem. So rather than getting them to the hospital, what we are saying is, can we create mobile ambulances with all the basic amenities, like we mentioned, point of care diagnostics. He talked about a decentralized model of having nephrology centers all over the country. So I'm saying we should create mobile units and address the problems of the patients there in the rural areas. And the other thing that has come out is that, see, we are working on home health, somebody else is working on electronic health record. The gentleman there talked about having a common digital identity. There's a project that we are doing with one of the companies on having unique identities which across, whether I'm with vendor A or hospital B, or in a government program, my data is integrated, my epidemiology is getting collected, and whatever my outcome, the health outcome is getting measured. So I think the need is to really create a common platform or a system where all the different vendors and all the different players, be it private, public, etc., can integrate and get a unified view of the patient. That I think is the real challenge.
Thank you, thank you. Now I request from that side, just in 2 lines, what is the take of this and what organizers can note that it can be included in the report, that what can be implemented in next 5 years. We believe in 5-year plan, so let's talk of 5 years.
Sure. I think the key takeaway for me is the provision of access to healthcare facilities. I think using telemedicine as an underpinning technology, I think it's a great platform. I would personally like to think telemedicine is like internet. You lay the road, you can run a truck on it, you can run a bus on it, you can run a cycle on it, you can walk on it. You can do whatever you want, but telemedicine is the one that will bring access of and expertise of acute care facilities into remote communities. They need it more than anyone else.
From my side, same thing. People harp on a lot on affordability. I think accessibility is a key issue in India, and as we increase it, it will automatically solve for affordability as the volumes increases. One thing about all the technological solutions that are coming out, we face a challenge that the medico-legal structure of India is very, not concrete, and that makes it difficult when you are treading some line. You don't know which side of the line you are falling on. And I think one thing that the organizers can note here, because you would know the governments better, to push for more structured medico-legal lines in India, so that when somebody develops a technology, he knows what he's trying to do.
Thank you.
There's no policy around home health care right now. So we don't know what is right, wrong, what are the protocols to set. So I think the government should probably think about setting up some ground rules for us to follow.
Thank you. Very, really good question. With the 2 billion market, and there are lots of players in that from India and abroad, small to big, Protea to this, that, etc. Because I've been reading all about it. So this is really what is really required. What is the standard? What would we call it, equality standards? Yeah, to my friend Sudarshan.
2 fundamental regulatory change which is required. One is telemedicine. At this moment, e-prescriptions are not allowed, and there is no clarity about regulatory guidelines on telemedicine. We need to come out clearly, because that will take the reach of chronic care much beyond the cities. That's point number one. Point number two is electronic health record system, which Nidhi was talking about, because the way chronic care is treated, records are very, very important. A lot of time is wasted of the patient. Every doctor has got his own way of looking at the patient. If we are able to come and standardize that process, that will go a long way in treating chronic care patients.
I'm going to make a controversial statement. Generally, all other industry, people go to market when there are 80% ready. Unfortunately, in healthcare IT, people go to market when they are 40% ready. I mean, I'm just being a little generous. So the end users have to really put their not skin, flesh and even bones in the game. So my appeal to them is be more ready and look at the solutions end to end, rather than trying to sell the products in islands.
Thank you very much. I think I have promised my next chairperson, Madhubala, that I'll finish in 1 hour, 15 minutes. And I'll not take your time. So the next 5 minutes, which I still have, I'll sum it up and I'll hand over to her. Now the issue are two. It's in lighter vein because very serious talks have already happened. I liked A.K. Singh, General A.K. Singh, is he around? Anyway, he used a technological word called graveyard of technology, and it stuck to me. Really so, more so in the government organization. Buying in a computer, PC, etc. is no issue. Maintenance is issue, replacement is issue. And you can't dispose it off, sell it off because of certain government regulation. So they are dumped. This has happened, I have seen even in Gujarat. One room is all filled up because old Windows, 7-year-old, and they are not using it. And some of this stuff was never used at all. It's something like as the UP government decided to give everyone laptop and it was sold in the market at some cost. So this was all dumped in one place. So he says he's looking after the whole telemedicine project of government of Rajasthan, and he says this is called graveyard of technology. I really like that word, and this is what happens with many of us, that we don't use technology. In the hospital also, some clinician buys something and it is to his fancy, and you don't use it optimally because everything has its life. 5 years is generally accepted. And the last anecdote I remember, when I was walking through in the morning, I found transformation of healthcare by IT. I remembered of my medical days. Some of my younger colleagues of my AFMC are here. In 1965, when this family planning business came in India, and a lot of controversy. So my dean decided we must have a debate, and a student should speak, and the professor should speak. So a student I was representing, and professor somebody else was representing. And ultimately the professors have 3 daughters, he was trying for a son. So that is one, and I was not married. And dean said in the end, 2 eminent speakers, one doesn't know family and second doesn't know what planning is. So this is what IT in healthcare transformation going to be if we don't talk to each other properly. Thank you very much. Thank you all panelists.
A very big thank you to the session panelists and the chair to the session. We now begin with the session number 5, on healthcare IT as a revenue system. The session chair, Ms. Madhubala Radhakrishna, is also the secretary and the founder she's also the vice president to HIMSS India, and she's also the founder president to MCura Incorporation USA. Calling upon Ms. Madhubala to kindly come to the stage. Requesting panelists Mr. Uday Kumar, Chairman and CEO OHM Healthcare Incorporation USA, Dr. K.K. Agarwal, Secretary General, Indian Medical Association, Mr. Tulsi Raj, Executive Director, Arvind Eye Care, Mr. Niranjan Kumar, CIO, Saganga Ram Hospital, Mr. Suresh Kuttachal, General Manager, Apollo. And we are looking forward to Dr. Deepak Agrawal from AIIMS also joining us, who will be joining us in a few minutes. He's running late.
Hello? Yeah. Good afternoon all. So our topic today is HIT as revenue stream. Healthcare IT as revenue stream. Yes, you heard it right. How long will we be spending? Let's also earn. So how healthcare IT is going to be a revenue stream, and this is going to add a new angle to the whole industry. When in HIMSS board, we discussed about the agenda, when Mr. Gupta suggested this, I just jumped in. This is where we are going to change the industry, because we don't have to spend any more for IT. IT could be a revenue stream if we do it properly, if we implement it properly. So what experts have got to say? We must be proud to have such an expert panel to discuss about this a great topic of healthcare IT as revenue stream. So I request the panel members to introduce themselves.
Check. My name is Suresh, and I run a couple of things at Apollo. I'm in charge of the CEO of the Apollo eDoc, which is an online appointment system of the Apollo hospitals. We kick in about 5 lakh appointments every year. I'm also the executive director of the Transforming Healthcare with IT conference, which is now due in Bangalore on October 16th and 17th. Thank you.
Thank you. My name is Uday. I'm the chairman and CEO of OHM Healthcare, which is a vendor in health IT. So I'm assuming that revenue stream for me is absolutely a requirement. But I'm guessing this topic is not about vendors' revenue stream. It's about hospitals and the care providers and the patients. So we should try to change my tactic.
Good evening all. I'm Niranjan Kumar Ramakrishnan. I'm the CEO of Sir Gangaram Hospital. Being a charitable hospital and a unique business model we have, where we don't get investors to come and pump in and we don't take profit out of it. So definitely we are a proven model for having a revenue stream within ourselves, and definitely IT is helping it out. And I have a few slides and case studies to show you that how it can be achieved.
I'm Tulsi Raj from Arvind Eye Care System. We have single specialty hospital present largely in Tamil Nadu.
I'm Dr. K.K. Agarwal. I'm the collective consciousness of 2.5 lakh doctors, representing as Honorary Secretary General of Indian Medical Association. I was also in the Ethics Committee of Medical Council of India for a year. And for 11 years, I am in the State Medical Council, Delhi Medical Council, and heading the Ethics Committee. So there will be 2-3 things which I would be able to cover. A, what is allowed, what is not allowed, as far as, because the previous speaker did talk about there are no regulations in digital health. There are, what is the current scenario, how Medical Council of India or a State Medical Council looks at it. And second thing is, the topic is very interesting. The topic is HIT as a revenue stream, question mark. The question mark is for whom? For the IT industry or for the doctor? And that's a big question mark, because if it comes to the doctor, then ethics, morality, ethics principles comes in. And as far as industry is concerned, we all know that anybody today who is entering into a digital market is making crores.
So coming to this, IT has been indispensable component in any other domains if we take. It could be travel industry or it could be banking industry. Today they cannot run without IT. But unfortunately, IT has not penetrated that level in healthcare. So what is the problem here? Is that adoption from doctors' end is a question, or patient doesn't, the impact of the IT is not benefiting the patient, because patient and doctors in any HIS system or EMR system out of this. So how do we make them as a stakeholder and make this as a total solution so that the industry is benefited? So I would request Mr. Uday Kumar to present about how doctors can adopt this. And we have a lot of questions also, lot of questions to ask the panelists.
Okay. All right. I can start talking, right? Thank you. And I'm going to change this presentation a little bit. And I'm changing it from HIT as a revenue stream to the return on investment on HIT, which is really a much more focused conversation, because when you talk about revenue stream, there are multiple ways to do it, but not all of us can afford to actually do revenue streams. But what we can all do is ask ourselves a question: how are we going to get back the money that we put into HIT, right? So let me start with the presentation. This is not playing. All right. So let me start with the idea of the revenue as a concept. And I think the reason to invest in health IT would be predominantly in 5 categories. The patient mix is changing. You have a higher competition. You have increased expectations from the patients, and then we talked about chronic disease management, devices, telemedicine, a lot of things that we talked about that we can do. And obviously the disease burden is going up as people age, and we have improved medicine. So we need to invest, that's the first. But the second question is, once we invest, how do we get the money back? So the challenge in healthcare is extremely complex. And if you look at it, there are 3 streams. The top stream right on the top is the patient's view, from the time that he's sitting at home to an initial consult, to getting his investigation done, to getting admitted to a hospital, to getting discharged, and then getting taken care of at home, the whole spectrum. The middle stream is the provider side, where there's a complexity of medicines, investigations, doctors, nurses, evidence-based medicine guidelines, medicines themselves, and then the integrated package billing that we essentially generate in order to generate revenue streams for the multiple players in that game. And the bottommost is the payer. And the payers can be broken down into the government, which obviously pays for more than 50% in most countries in the world. The insurance companies, which is very low in this country but is quite high in others. The family and the individual himself, who's paying for 65 to 75% of the total cost. The corporates, the employers, who are paying for it in some form or shape, either because they lost days, because of sick leave, or because they actually have to pay for the insurance. And finally, charity organizations, which essentially say, out of love, out of compassion, we have to pay for it. So there is a complex scenario, and in this complex scenario, health IT has to work. Now, if I look at it from a different perspective, healthcare is a variance game. It's a volumes game. And if you look at a simple idea, and I'm just looking at it from a hospital perspective, a 600-bed hospital has 30 million patient touch points in less than 7 years. And that's simply 1.2 million lab tests, 450,000 images, 8 million drug orders, 120,000 procedures, and 230,000 approximately absent or vacant bed days. All of this has to be managed in a process. And this is not easy to do. And when you try to do this, that's when you come across investments, and the return comes from managing the variability of this. So if you're looking for an 80% efficiency, which is what most Indian hospitals are today, you're generating 5.4 million errors in a year. And if you go for a Six Sigma, you're basically trying to bring that down to 27 errors across 30 million patient touch points. Not possible to do without technology. It's estimated in the US alone, the number of deaths attributed to errors is the equivalent of 2 Boeing 747s crashing every single day. And that's a large number. So when you look at it from safety perspective, there is an immediate payback. And the Institute of Medicine defines the quality of healthcare investments along the lines of being patient-centered, effective, safe, timely, efficient, and equitable. And so almost all returns come from that. This is a study by McKinsey. And McKinsey made two statements. If you invest in IT alone, you can get up to a 4% improvement. If you invest in process reengineering alone, you can get a 9% improvement. But if you invest in IT and process, you can get up to 24% improvement. And when they say improvement, actual cost to the bottom line, actual improvement in revenue, actual safety, actual lower costs. So when I look at returns, I can essentially ensure returns. So what kind of investment is required? There are two. One, you should have as much patient history as possible. And second, you must have as much clinical practice as possible. The trick is to bring both to the same screen at the point of care. And if you can bring these two to the point of care, you will achieve up to 24% improvement. And that will improve across the entire platform. Every single process listed out here will improve. And that improvement will show up in your